Hello and welcome everyone. My name is Shira Lisha and I'm an HoFH patient ambassador and the project lead for HoFH Awareness Day. And I'm delighted to be co-moderating this session with Professor Albert Bigman. Today's webinar is the third and final part in our special trilogy, which is part of the HoFH Awareness Day campaign. And this session focuses on the latest breakthrough in HoFH treatment, highlighting the recent trio of therapies, PCSK9 inhibitors, lomitapide, and evinacumab. These cutting-edge treatments are transforming the management of HoFH and giving patients more options for improving their quality of life. So as we have seen throughout this trilogy and in the previous two webinars, the essence of these discussions reflects collaboration. So our webinar is designed to be interactive with discussions between medical experts and patient experts, showcasing the real partnership between the communities. So we have a very exciting and engaging 75 minutes ahead of us. But before we begin, a couple of housekeeping notes. So this webinar is being recorded and will be available on the FH Europe Foundation's YouTube channel. If you have questions, please post them in the Q&A box and we'll answer as many as we can live. But please avoid asking specific questions related to personal healthcare health records. We'd also love to hear from you, so please share who you are and where you're joining from in the chat box. Now, without further ado, it's my pleasure to introduce my co-moderator, Professor Albert Bigman, an amazing pediatric cardiologist and researcher from the Netherlands and a member of the Scientific Advisory Committee of FH Europe Foundation. So over to you, Albert.
Thank you, Cheryl, for this kind introduction. And it feels great that we have now the trilogy, the third of the trilogy, where the first two were also exciting, but we do have three wonderful experts and three fantastic ambassadors filling in this 75 minutes. And I think we will start with Professor Luis Massana. That's the idea, to talk about lomitapide. Professor Luis Massana is professor of medicine at the University of Rovira, Tarragona in Spain, and he is one of the leading experts in this field. So I hand over to him. Please, the floor is yours.
Thank you, Albert, for your kind introduction, and it's for me a pleasure to take part of this webinar on the use of new therapies for homozygous FH. I'm going to talk about lomitapide. In this figure, you see the scheme of lipoprotein metabolism. As you know, the liver is the center of operations of metabolism, and liver synthesize lipoproteins, particularly VLDL, which is the first lipoprotein that is poured into circulation by the liver. And after metabolization of this VLDL becomes an LDL. The LDL is usually taken up again by the liver through a molecule that is called the LDL receptor. 80% of the clearance of LDL is in the liver through these LDL receptors, but 20% is also cleared, is extracted from the blood, from peripheral tissues. The remaining LDLs could infiltrate the vascular wall, leading to the production of atherosclerosis. In patients who have problems in synthesizing these LDL receptors, it will be an accumulation of LDL. This is the case of patients with FH. In the case of heterozygous FH, we have good news because the usual drugs that we use in our clinical practice as statins, ezetimibe, bempedoic acid, PCSK9 inhibitors, etc., act by increasing the number of LDL receptors. By increasing the LDL receptors, what we have is an increased extraction of LDL, so the concentration of LDL is reduced. Also, there is an increase in the extraction of LDL through peripheral tissues, so the remaining LDL is decreased and the lesion in the artery wall is less severe. The problem is with patients who have homozygous FH. because people with homozygous FH cannot or are very limited in its capacity of synthesizing LDL receptors. So these usual drugs that act, as I mentioned to you, by activating the production and the function of LDL receptors cannot, at least is not effective enough in this group of patients. So we must go to look for other pathways in terms of therapy. Of course, that if we cannot remove the fat that is already in blood, why not trying to avoid this fat to achieve the bloodstream? And this is what lomitapide does. There are two pathways where fat achieves our body. One is through the gut. The enterocytes absorb the fat that we eat, and this fat is bound to a protein, ApoB48, thanks to the presence of one protein, very important for us, the MTP, microsomal triglyceride transfer protein, MTP. And MTP helps to bind fat with ApoB48, producing chylomicrons. This is one way we have to absorb fat. On the other hand, the hepatocyte does the same with fat inside of the hepatocytes, and with the collaboration of MTP and ApoB100 form the VLDL. What lomitapide does is blunting this MTP, avoiding the reduction of both VLDL in the liver, chylomicrons in the enterocyte. And this is helpful because it works at clinical level. We have data that lomitapide is able of reducing, this is a study performed in 75 homozygous adult FH. And as you see here in percentage, the use of lomitapide after many, many months was associated to a very significant decrease in the LDL concentration. This is in percentage. Here you have the absolute values. People starting with LDL of 300. These people was already on previous LDL lowering therapies, so they had a mean LDL of 300 when they were put on lomitapide. And you see how many of them achieve LDL values below 100, and a mean reduction, an amazing mean reduction of 60% in terms of LDL concentration. However, homozygous FH should be treated from childhood, and we have performed a study in 43 children from 5 to 17 years, and we gave lomitapide to them. And as you can observe here, the reduction in LDL was about 53.5%. This group was divided in the younger ones, 5 to 10, and in those from 11 to 17, and the reduction was similar. So in the younger ones, the reduction was 56.5, in the older ones was 51%. So 42% of them, on top of that, achieved the LDL objectives, less than 35 milligrams per deciliter. That was the objective in that time when we designed the study. So lomitapide is a nice drug. It's a small drug that can be given orally, 1 pill a day. If the dose is high, probably 2. Acts through an LDL receptor independent pathway, is extremely efficient in reducing LDL in this group of people, and because blocks the production of all ApoB-containing lipoprotein, you're reducing all, not just LDL, all atherogenic lipoproteins. However, happiness is never complete, and we have some side effects. Of course, if we stop the exit of fat from the liver, where is this fat going? Well, this fat is staying in the liver, so there is a danger of developing fatty liver that we have to monitor. On the other hand, we stop the absorption of fat. Where is this fat that is not absorbed? In the gut lumen. Producing what? Producing diarrhea. But not just diarrhea, but probably some important fats that are necessary for us. So, for example, liposoluble vitamins or some essential fatty acid probably would not be absorbed. So the other phase of lomitapide is that can produce diarrhea, essential malabsorption of essential fatty acids, vitamins A, D, E, K, fatty liver is also a little bit expensive. So there are some problems associated to the use of lomitapide. But here come the good news. So all these side effects can be successfully managed clinically. So we can administrate supplements of vitamin E, supplements of essential fatty acids, and also we put our patients on a very strict low-fat diet. Low-fat diet means maximum of 20 to 30 grams per day, which is a very difficult diet to be followed. And we, in fact, elaborate this cartoon showing each square means 5 grams of fat, and each fruit has a number of squares. For example, if you eat a stick, 120 grams, so you have 3 squares that contains 15 grams. So you know exactly how many squares can you eat to have a maximum of 20 grams. And also, the other good news is that the liver function, by managing the dose and controlling liver enzymes, etc., can be well controlled. This is another study with a number important of participants and with an important extension too. So we can maintain the liver enzymes within normal ranges, and also the elastography showing the rigidity of the liver can also maintain within normal ranges. So what I'm saying that lomitapide is offering to you is that this pathway between health and cardiovascular disease that in homozygous FH many times is associated to the use of LDL-A apheresis. Probably we can change this by 1 pill, or as you will see in the next talk, with a perfusion a month. Thank you very much for your attention.
Thank you so much, Professor Massana, for this excellent talk. We will come back to you, but I hand over to Shirel.
Yes, indeed, it was excellent, and it's empowering to have this knowledge, and I'm sure everyone here can agree. Now, joining us are Elsie Evans, HoFH Patient Ambassador and Ambassador Program Project Manager, along with Marwa Sadiq, an HoFH Patient Ambassador. Now, Elsie and Marwa, I'm sure you have important thoughts to share, so I'll hand it over to you both, but starting with Elsie.
Thank you very much. And thank you, Luis, for it's really informative, especially the diet picture that you shared. It would be great to actually share that with more people because, as you said, it's really difficult. So I live with homozygous FH and I'm on lomitapide. I've been on lomitapide for a few years now. And the diet is probably the trickiest bit to manage, especially if it's something new that you're coming across. It might be easier as we're going forward with children, but for somebody who we were on a strict diet, but it's not necessarily as restricted. So it is very different. But I was wondering if you could kind of say a bit more about how, what might contribute to the increase of cholesterol levels if you take lomitapide for a while, because I've been on lomitapide for a few years, it's stabilized really well. And then there was a fluctuation in levels. Is there something that might happen, whether it's hormone changes or anything like that?
I have not a proper answer for this. We have seen similar things in one of our patients that was well controlled and theoretically maintaining exactly the same therapy. So the LDL cholesterol levels went up again. But I think that there are external factors that probably contribute to the lack of effect in some periods of life or in some periods of time. And probably I will maintain the therapy just to see if the LDL reduction is recovered, because sometimes subtle things associated to diet, to other medication that has been taken, or medication that has not been well absorbed, or other factors in women, for example, some hormonal changes, etc., could also contribute to the lack of efficiency during or across time while on lomitapide. There is no, of course, there is no, in those studies that I showed to you, there is no mention to people that had a kind of increase of LDL during therapy. But of course, one thing are the clinical trials, and the other one is the real world.
That's great. So we'll kind of keep an eye on that and see what comes out from the studies. But we said about the diet, and obviously that is quite a restriction. Is there kind of something with the diet and lifestyle modification that you recommend for patients that help? I know you said about supplements.
Well, to avoid liposoluble vitamin deficiency, it is established that we must give some supplements of vitamin E, which is the more important one because it's antioxidant, etc. However, I'm doing it, or our group is doing it, but when you measure vitamin E levels in patients with homozygous FH, they have about twice the concentration of people without homozygous FH because vitamin E travels with LDL. So because the LDL levels are so high, in general, you have high levels of vitamin E. Anyway, after therapy, the vitamin E goes down and is maintained in normal ranges. The other supplement also is the use of what we call essential fatty acids, mainly some omega-3 fatty acids that are needed for different functions in our body. So we want not to risk the possibility of having a deficit in these fatty acids. It's very simple to take one of these supplements. It's one pill a day, and you have all the needs fulfilled, so you don't need to do anything else. The main point is reduce the total amount of fat during your diet. This is the key point to avoid at least the gastrointestinal problems that can be produced by lomitapide. I know it's a tough pill to take. It's just a pill. It's a tough pill. But we are addressing a severe disease, and the alternative is really, so I think, limiting the quality of life of these people. You probably know this better than me. And I think it's worth trying to follow this diet. We have the experience with children. Children tend to be more difficult in order to follow a particular diet because they want this and that on TV, or they say it's good, I want to have it. Well, the problem is that they have a donut, they will have diarrhea that day. That is the only problem that they have, and they will learn about this, and they used to follow the proper diet with time.
It is really tricky, but I will say I agree. It is the change. For me personally, apheresis was quite an impact. So having a tablet to take compared to apheresis, it is a perception which one is the easier one to manage.
And you can,
last one for me.
Sorry, I was about to say that you can imagine a parent when brings his son or daughter to us, and we say, well, your 5-year-old son will need to come once a week or twice a month to our center to have an LDL apheresis, at least the morning with us. So we will extract the blood, we will clean it, and we will put it back to you. It really is a difficult conversation to maintain. Yeah.
Absolutely. Last question from me, then I'll hand over to Marwa. It was just about effectiveness of lomitapide. Have you found in the studies you've done so far whether there's age or gender makes a difference in how effective or how the levels? Because I know that for some of us, they get to 10 milligram and everything stabilizes and is quite well tolerated, and others have to go up to 25 or 30 milligram. Did you find that there was any difference?
There are individual differences in terms of sensibility to or the effect of lomitapide. So individual differences, but these individual differences are not associated neither gender nor age, etc. So probably are other aspects that make us different one by one, regardless of sex or whatever. And yes, there is people responding 80% and others responding 30% in terms of LDL lowering.
Wow, that's amazing. Thank you very much.
Thanks.
Hi, everybody. I'm Mara. I'm an HoFH patient, and when they found out I had the disease, I was 3. Again, I've used lomitapide myself, and it is life-changing, I'd say. And then sometimes I think I wish I had this when I was a child, which brings me to the question to the Professor Masana. What is the usage of it now in children? What's the testing? What's the latest studies? How effective it is on pediatrics? Do you see any difference between the adults and use on the adults and on the children?
Well, I showed to you I think that the latest data on children. This was a study, was an open study. We do not include children in any placebo arm. We thought that it was not ethical to give a placebo to a group of patients with homozygous FH. And as I showed to you, so we include 43, more than that, but at the end we had 43 patients from 7 different countries. And what the data we have that we will publish this month in the Lancet Diabetes Endocrinology show so that lomitapide is able of reducing the LDL concentration by 53%. But this is associated, and we have data also from a previous study in real world data, is associated to a reduction in the number of LDL apheresis sessions. So in the previous study with 11 kids that were on LDL apheresis, many of them, and we put them on lomitapide, so 38% of them reduce the increased intervals between LDL apheresis, and some of them quit the sessions of LDL apheresis. So I think this is an immediate impact on quality of life of the affected people. And by affected people, I mean kids and relatives, because relatives also are suffering around the situation of the people affected.
And so
this is the latest thing. Sorry, just to complete my answer. So the data we have so far is the efficacy in 24 weeks, but these kids has been followed for an extra 87 weeks. So we will have more than about 2 years of follow-up of this, and these 2 years will be used for safety data with the use of lomitapide. I can tell you that the side effects observed with lomitapide are more or less exactly to those observed in adults. So people with gastrointestinal problems, in some of them a little bit of transaminases that you reduce those and goes back, this kind of thing. So they can be handled in a very in a very good way.
That was going to be my next question, is what's the major difference in the side effects between adults and children? But as Elsie said, with the lomitapide, it comes knowing that we grew up knowing we should have low-fat diet. So I had to relearn that it's not just good fat and bad fat. With the lomitapide, it's fat, so it's whether it's olive oil or fat or animal oil, fat, sorry. So that was one of the challenges. So where do you see this going in the future for the pediatric care? When it comes to pediatric care, do you think that's going to be safe use for them in the future, as as a kind of light of hope where it changes? As you said, as a parent myself for 2 children, luckily they're not HoFH, but looking back at myself when I was a child, it would have changed my parents' life and the quality of life, because with the LDL apheresis, you can't leave it for long, you can't travel for long. So what do you see the future of lomitapide when it comes to children?
Well, I think that the quality of life is going to change. So I think the paradigm of homozygous FH, I think this is something that we have to discuss after the three talks, but I think will change. For me, although in the latest guidelines is already considered a first line, well, not the first line, before that we have all standard lipid-lowering therapies, but after all the standard lipid-lowering therapies, I think lomitapide and evinacumab too probably will become the first line therapies. And in some people probably you will need, I think that Well, we will discuss it later, but the use of lomitapide, probably in combination even with evinacumab, will avoid all kind of LDL apheresis. And if there is no access to both drugs, in some cases, probably you will need to complete therapy with LDL apheresis, probably with less sessions of LDL apheresis than the ones that we're doing now.
Thank you, Professor. Thank you.
There are so many questions already, but some you already answered or were asked by Elsie or Marva. One is still the dosing in children, should it be lower than in adults?
Yes. Well, in this particular study, we start with a very low dose, particularly in the younger ones. We start with 5 milligrams, but we were up titrating the dose every month according to the LDL levels. And in the younger group, we achieve a dose of 20 milligrams a day. And in the older ones, we increase to 30 and even to 40 in some patients.
Yes, yes. And in many questions, it's not a question, but the low fat is imperative. You should use low fat. That's no discussion, no doubt about it.
It depends how happy you are having diarrhea. So if for you to have diarrhea is okay, well, okay, no problem at all. But if you feel a little bit upset with this problem, oh, for sure you will need some to diet a little bit, yes.
In the interest of time, we can come back to you at the end.
Okay.
We continue with the next guest.
Okay.
And he was already on the second webinar as well, then talking about apheresis, but Antonio Gallo, Professor Antonio Gallo from Sorbonne University, specialized in cardiovascular prevention, is also really known with another drug that works independently of LDL receptors, evinacumab. Antonio, floor is yours.
Thank you very much, Albert. And hi, everyone. It's a pleasure to be again with you. So today I'm going to talk about this second component of the trilogy in the trilogy. So this new set of 3 treatments, so evinacumab. And these are my disclosures. So I've decided to start by taking you on a little trip to Italy and to talk about this village where I went, where I was a resident with Professor Arco, who is a lipid expert in Italy, a small village close by Rome, where live a small group of people that are actually centenarians, because it has been found that they have very low levels of cholesterol, and these very low levels of cholesterol were associated with very low cardiovascular risk. We went there to study this population, and from this population, a mutation has been found in a specific protein that was cut off in its function, and that was associated with a loss of LDL cholesterol and a very low levels of HDL cholesterol. This protein is the angiopoietin-like 3, and it has been the target of this new treatment, which is the evinacumab. So what it is, evinacumab is a human antibody. You will find a lot of drugs nowadays that are called, that end with umab. This means actually that it's an antibody, so it's a protein that targets a specific target, and that is actually almost completely human. And the target of this antibody is angiopoietin-like 3. So angiopoietin-like 3 is a protein that actually intervenes in the metabolism of lipoproteins that are pretty rich in triglycerides. And it blocks this LPL, which is the lipoprotein lipase, which is supposed to disrupt these very rich particles in triglycerides, and to actually allow the transformation and the metabolism of these particles. Now, when a lot of these particles reach in both triglycerides and cholesterol accumulates, they can actually induce the presence of plaques, of atherosclerotic plaques in our vessels. So evinacumab blocks this angiopoietin-like 3, which is an inhibitor of this enzyme, and inhibiting the inhibitor allows this enzyme to work much better, and so to decrease the levels of these triglycerides. Triglyceride-rich lipoproteins, which happen to be also atherogenic, and so there is a decrease in the production in the end of LDL cholesterol. Now, we know that in homozygous FH, there is almost no LDL receptor, but the action of this treatment seems to be independent on the LDL receptor action. So how does it work? It's a treatment that is given intravenously. So it's an administration that happens once per month. The dose is going to be adjusted to the weight, and the administration lasts about 1 to 2 hours. For patients living with HoFH that are already on LDL apheresis and that need to be on this treatment, the administration takes place at the end of the session of LDL apheresis. This treatment is now available for adults, but also for children, starting from the age of 5, because studies have shown an efficacy and a safety of this treatment in both adults and children living with HoFH. Here are some results of the primary study that was conducted on 65 patients living with HoFH that were already on a stable lipid-lowering treatment. And you can see on the left of the screen that a reduction of LDL cholesterol of about 47% was observed along the first 24 weeks that were that corresponded to the duration of the study. The study has been prolonged over 24 further weeks, and so for a total duration of 48 weeks now, we could see that the reduction of the LDL cholesterol was stabilized, and actually the treatment was very effective over the long term, with a reduction that was around 43 and 55%. So we are talking about reductions that are very important because these are reductions on top of already available lipid-lowering treatments. I wanted to show you some real-world data because that's what happens in the studies. But as Professor Mazzana said, sometimes there is a difference in what we see in the real life. And these are just this is the clinical evolution of 7 of our patients here in Paris. You can see the levels of LDL cholesterol were pretty high without any treatment. The addition of statin and ezetimibe already was associated with a decrease of almost 40%. The apheresis also contributed with a further 45 to 50% reduction. PCSK9 inhibitors didn't work very well in this specific set of patients, but we will talk about this maybe later. And when we added the evinacumab to these patients, we had a further 55% reduction. I just want to highlight the fact that we achieved unachieved levels of LDL cholesterol ever before in the history of this disease. So we almost normalized the lipid profile of patients living with HoFH with this treatment. This is the case, for example, of a young male patient of 19 years old who started apheresis very early in life. He started at the age of 3, who was on LDL apheresis bimonthly with atorvastatin and ezetimibe. There was the introduction of evolocumab that is an inhibitor of PCSK9 that was not that significant. And then once we introduced evinacumab, as you can see, the LDL cholesterol levels went really down, and this allowed us to reduce the frequency of LDL apheresis. And this is also another example of another patient with cardiovascular disease that also was put on apheresis at first and then on evinacumab, and you can see how the lipid profile and the LDL cholesterol levels went really down once on treatment. And this was also associated with a surprising disappearing actually of you see the xanthomas that were still present in this patient at the tendons of the hand, which was quite surprising, and which actually confirms the efficacy of the reduction in the cholesterol burden, in the exposure to very high LDL cholesterol levels in these patients. So what are the side effects of this treatment? It's a treatment that is really overall very well tolerated. All adverse events, both in clinical trials and also in our experience, have been considered pretty mild, and they might correspond to some flu-like symptoms or some headaches sometimes, mostly occurring at the first administration. So what we do is that we take it a bit longer to perform the first administration, which doesn't necessarily happen in 1 hour, but maybe in 2 in our real life experience. And this allows us to not experience at all this kind of effects. There have been no discontinuations of the treatment. The only cases of discontinuations have been 1 patient because of a headache and 1 patient because of a pregnancy. This is a treatment that we cannot administer during pregnancy. So if there is a project of pregnancy, of course, the treatment has to be interrupted. What about the effects on cardiovascular disease? This was also another very important news that we could share and publish recently on patients from France, where we compared patients that had treatment with evinacumab to a subset of patients not still on this treatment. And we could observe that in patients treated with evinacumab, we did not experience any cardiovascular event over 3.5 years of treatment. So this has been another very important information to add to the efficacy of this treatment, that apart from lowering LDL cholesterol, of course, reduces also the risk of cardiovascular disease. So to end, we can just summarize by saying that evinacumab is a treatment that is quite life-changing, actually, a bit as lomitapide, that has been demonstrated to be very efficacious in all patients living with HoFH, independently from the mutation that they carry, that this efficacy is proved on the long term. There is quite a safety profile with very low incidence of side effects, and this stable LDL cholesterol lowering really results in a reduction of cholesterol burden, and also is associated with a cardiovascular benefit. And I thank you for your attention.
Thank you so much. We will discuss, but first, Cheryl.
Yes, I was quite mesmerized by this presentation. So thank you. And it's remarkable to see how this therapy works, and to see how there's no size-fits-all when it comes to managing HoFH. So with that, I will move on to Mariana Stephen, HoFH patient ambassador, who brings her personal experience and insights on this treatment. So Maria, the floor is yours.
Thank you, Sheila, for the introduction. Hello, everyone. I'm Maria. I'm an HoFH patient and FH Hero Foundation patient ambassador, and I am on evinacumab since 2020. So it's been 4 years now. And luckily for me, I didn't have any side effect. So my first question for you, doctor, is for patients who did have side effects that I know from my fellow patients. If we manage these side effects, can they put back on evinacumab?
So the prevalence of side effects with this treatment is really low. So as I was saying, the few reactions that we have had, which were for example, some paresthesia, feelings like a little bit, weird feelings on the face that were swelling, or at the levels of the hands or the feet, were really symptoms that disappeared after the first perfusion of treatment, and also that might be related with the speed at which we do this administration. The fact of reducing the speed of the administration for the first two, at least for the first two administrations, can really help managing these side effects. If we can confirm that these side effects were really associated with the treatment, which means that we can show that administrating the treatment triggers the side effect, then we have to be really cautious in trying to give it back to the patient. But if we are not sure of this, what we call causality, I mean, of this link between the administration of the treatment and the presence of the side effects, then we can try. But of course, we need to find the cause, the main cause of the side effects that is reported by the patient.
Okay, that's very interesting to know. And from your presentation, you have shown that the level of LDL cholesterol was down very drastically with evinacumab. But what does it mean to a patient? Will they have less statins or ezetimibe or less apheresis? What does it mean to have introduced evinacumab in their treatments?
Yeah, this is a very important point, because this we can say it's a life-changing treatment, but it's a life-changing treatment not only because it lowers LDL cholesterol, because it's by lowering this way LDL cholesterol with just a perfusion that needs to be done once per month, it can actually have an effect on the quality of life. I'm thinking mostly about patients that are on weekly or bi-monthly LDL apheresis that might not need to have all these LDL apheresis sessions, or for patients with, of course, it depends on the cardiovascular disease underlying and on the cardiovascular risk. But overall, having a treatment that is so efficacious, we can really think about spacing the LDL apheresis, and so reducing, the psychological burden of of this very tough treatments.
Yes, of course, that's a great news. So for HoFH patients, my last question is, as a doctor, how can you convince regulators to make evinacumab official for HoFH patients?
Yeah, so this is a very important, it's a very important point, because what is really important is actually to show the evidence. So to show that the treatment is really efficacious and safe, that it can have also, effects on cardiovascular disease, so that it can really also prevent the onset of complications related to the disease. And for this, we need to really be working together with patients, because it's a teamwork, when definitely health professionals and patients together need to go and fight together to get access to these treatments.
Yes, of course. It's very interesting, Doctor, and thank you so much for this enriching and very informative presentation. Up to you, Chiral.
Yeah, and shall I ask some questions that come from the audience? There are too many questions still, also questions coming in about lomitapide, so we will continue with that as well. You brought it that enthusiastic that there is a question, why isn't it approved for heterozygous FH, evinacumab?
Yeah, this is an interesting point. I mean, in the strategy for getting access to this treatment that are still, I didn't mention, but that are still quite expensive, and that are still quite invasive, because we are still talking about getting an access through a vein with a needle through. I mean, we need to be at the hospital to have this treatment. There might be, for heterozygous familial hypercholesterolemia, already very well-performing treatments that might not, that might be much more easy in terms of use, in terms of administration, and that are as efficacious evinacumab, and so that for heterozygous FH, we might not need to go through this treatment that is, LDL receptor independent and that has a specificity of action. This might not be needed for the heterozygous form. We have actually other options, and I think that Professor Santos is just about to go to talk about them. I
agree. Another question is, for evinacumab the same diet required to avoid the side effects, so as fatty liver?
Not at all. We are talking about a completely different mechanism, and so we are not blocking fat in the liver. There is no action on there is no risk of hepatic steatosis, of fatty livers, or gastrointestinal side effects. So it's a treatment that works in a completely different way, and that for this reason is not associated with the side effects.
That's fantastic news. I think we are entering a new era where you can have oral drugs with a strict diet versus once per month intravenous without that diet. There are many more, but I come back to you later on. We first continue, and we all will sing at home for his birthday. Professor Raul Santos is with us on his birthday. He is the director of the lipid clinic at the University of Sao Paulo, Brazil, and he is an expert in many fields, but also on PCSK9 inhibition. Raul, the floor is yours.
Thank you, Bert. Hello, everyone. Today is my birthday, so I'm very happy to share it with you. Okay, so let me just share my slides here. Okay, hold on. So basically, my life has been made a lot easier with the first two presentations talking about the therapies. But I think PCSK9 inhibitors, despite the fact that they're less effective than the other two drugs that have been presented, still have a role in the prevention of cardiovascular disease in people with homozygous FH. So this is my conflict of interest with some pharma companies. And basically, this is how we separate the drugs that we use to treat familial hypercholesterolaemia, not only homozygous FH, but also heterozygous FH. So here you can see the drugs that depend on the LDL receptor. So you have to express in some manner the LDL receptor for these drugs to work. So we have the statins, ezetimibe, we have the PCSK9 inhibitors, right? On the right-hand side, we have the drugs that act totally independently of the LDL receptor, as has been shown before by Luis, lomitapide, and evinacumab by Antonio. Also, we have LDL apheresis. That's not a drug. It's a procedure that takes away the bad lipoproteins from the blood. And also, we might have liver transplantation. So in theory, if you do not express the LDL receptors, you should not take the PCSK9 inhibitors. But I'm going to show you that there's a very heterogeneous response to these therapies, and it might work a while try the PCSK9 inhibitors before moving to more expensive drugs like lomitapide or evinacumab. So this is data we published. This is 4-year follow-up of one of the PCSK9 inhibitors that we have, evolocumab. So you can see here we had 300 people with very severe familial hypercholesterolemia, not only HoFH, but heterozygous FH. You can see we have a big number of people with HoFH here, more than 100. And you see that we were able to reduce the LDL cholesterol by an average of 20% in those with homozygous FH, with lots of variability, as I'm going to show you. And for heterozygous FH, we had reductions of around 50%. So certainly all of you have children or have parents or have brothers and sisters that might have heterozygous FH. And definitely PCSK9 inhibitors came to really change their lives for good, because with these drugs, we can really normalize LDL cholesterol in a big number of people with heterozygous FH. But what about HoFH? As I showed you before, so on average, we have a 20% reduction in LDL, but many patients might not respond at all to the therapies. And you can see here that actually those who took evinacumab have very variable responses to the therapy. Sometimes this is explained by the genetic background, by the mutations that some of you guys might bear, but it's not necessarily like that. It's not at 100% straight thing like mathematics or physics, you know, because actually people with the same mutation might respond differently to the PCSK9 inhibitors. So that's, as I said, we should, even if you have, let's say, a genetic test that says that you're null, you have a null variant in your LDL receptor, you may respond to a PCSK9 inhibitor. This is, it's a little bit weird, but this is what happens in clinical practice. So, and there's a beautiful study by Gilles Lambert and colleagues from France and from South Africa that actually studied the expression of the LDL receptor in the cells of people with HoFH with the same mutations, and there was variability on the response. So this is something that needs to be considered. We have actually the injectable PCSK9 inhibitors like alirocumab and evolocumab, where we can give our patients one injection every 15 days or every month. But there's another PCSK9 inhibitor that is inclisiran, right? You all know inclisiran blocks PCSK9 by reducing the production of PCSK9 by the liver. And the good thing about inclisiran is that you can give in the first year just 3 injections, and after that, 1 injection every 6 months. So that will make the life of our patients much better, considering the number of injections, etc. But this year, there was a paper that was published on Circulation, a very famous journal from the United States, showing that on average, inclisiran reduced LDL by 1% in people with homozygous FH. But as you can see here, we have patients that cholesterol went up, and we have patients that cholesterol went down with inclisiran. So I think it's another option. Inclisiran is not as potent as the monoclonal antibodies like alirocumab or evolocumab, but may reduce, as you can see in some patients, LDL up to 60, 70%. So this is something that we should consider. So if you really go to the literature, my friends, and you check the average reductions in LDL with PCSK9 inhibitors in HoFH, you see between 10, 20%, even less, sometimes more. And there's one number at least that we should say, okay, I should keep my patient with the drug, or I should stop giving the medication to my patient. And the number that we consider that would be clinically significant is a reduction of at least 15% in LDL cholesterol levels. Because let's think that if you have an LDL of 400 milligrams per deciliter and you had reduced by 15%, you reduce LDL by at least 60 milligrams. So I think it's a nice number to remember. So, and if you give the drug, stay with it for, let's say, a month and a half, and your LDL does not go down at least 15%, I think we should consider stopping the medication. So basically, this is how we should think about it. And why am I insisting on this? Because actually PCSK9 inhibitors may be beneficial for a lot of people, and they're much less expensive than lomitapide and evinacumab or even the apheresis. So especially in low middle income countries like Brazil, they should be, let's say, a much more affordable therapy that could be used by our HoFH patients in order to try to reduce the burden of LDL cholesterol in the blood. So what are the future options? As Albert said, now we're starting to have oral therapies, novel oral therapies to reduce cholesterol. And actually, PCSK9 inhibitors are being developed to be given as a pill. This is data from the usual population. We're not talking about people with FH, neither heterozygous nor HoFH, but you can see here that it works in people without genetic dyslipidemias, and it's as potent as the injections. So for someone who doesn't like to take an injection, I think this in the future could be an alternative to reduce the LDL cholesterol. And as I said, even if it's, let's say, it's not so robust as evinacumab or lomitapide, definitely the safety of PCSK9 inhibitors is huge. And as you might have, as I said, family with heterozygous FH, certainly these drugs will make a lot of difference for your loved ones. And hopefully also in the future, we might have these oral drugs. So maybe some of you might benefit from them regarding the posology. And hopefully they can help reduce the LDL and prevent the complications of cardiovascular disease. So to conclude, we have variable responses with the PCSK9 inhibitors. They should reduce the LDL cholesterol at least 15%. They are very safe drugs. They're much more affordable than other therapies. And we have different ways of administering these drugs. So thank you very much. And now I think we have some time for Q&A.
Thank you for this short presentation, and wonderful that keeps the spirit in and time for discussion. But Shira, first you hand over.
Yes, I agree. It's incredible to see the impact these treatments can have on managing HoFH. So now to continue the conversation, I'm pleased to invite Marwa again. Marwa, I know you've had experience with PCSK9, so over to you.
Thank you, Professor Santos, for the incredible presentation. It was really interesting, especially for me. So I use PCSK9s. I was told initially that I can't use them because I haven't got any receptors. With my first doctor that I was treated under, they refused to give it to me because they said it will be no use to me. I don't have any receptors from my genetic testing, and it's not going to be effective. Then I moved to a different hospital. I was under a different team. And then they told me, yes, we're going to give you the PCSK9s. And I was taken back. I was like, okay, I was told it's not going to be effective. They said, no, it's worth trying. I used it. I was taking 3 injections biweekly. I've been doing apheresis for so long, and my fellow patients know we hate needles. Even though we're so used to them, we still have a little bit phobia of needles, especially me. So the challenge for me was actually injecting myself. 3 needles in the stomach every other week was a bit of a challenge. I don't enjoy it, and I still don't like it. So it's great to hear that it's going to change into an oral tablet. It'll make a huge difference to us. To be honest, I was disheartened when I started taking it because I've got my parents, they take it. They are FH patients, so they're heterozygous. With them, as the professor mentioned, their reduction was 50, 60%. My dad especially had a significant reduction, and I was getting about 12, 13%. And I never dared to ask why. It was always, should I ask? Should I not ask? Is it okay to say, hey, how effective is this on me? So there goes my question, Professor. How do you decide who's the ideal candidate for this drug as an HoFH patient, as a doctor and a professor? How do you decide this is the right patient for this treatment?
No, this is a great question, because if we discuss the findings of the genetic testing with the geneticists, like say my good friend Mafalda Bourbon from Portugal, Mafalda would say, look, Raul, you should not give this drug for this patient because it's no, it doesn't express the LDL receptors at all. But as I said, it's not like a mathematics. It's not let's say something that is totally straight. And in my opinion, we should try independently of the results. Definitely, if you have, let's say, defective variant, so not so bad, the chance of having a greater answer and greater response to therapy is higher. But even in people who are no, I think we should try and see what happens. And we can see that very quickly. In a month, we already will know whether the patient will respond to therapy and whether therapy will be good for she or for him. So this is how I see it, and as I said before, so the advantage of this therapy is that's much cheaper than the other ones. It's not as robust. I agree with you on average, but let's say if you're lucky that you respond to it. We have people that might have 60% reductions in LDL cholesterol with the PCSK9 inhibitor, as I showed you. So definitely, we should try and see what happens,
Thank you, doctor. But now we have those 3 therapies that we've discussed, and they all are amazing, and quite lucky to live in this day and age where we have those options. But when a patient with HoFH come and speak to their doctor, what would be the discussion? How can they choose between those 3 therapies? Can you mix these therapies? Can you offer them, let's say the PCSK9s and a lomitapide, or how do we decide the right path or package for that patient? The discussion between the patient and the doctor and the medic. How open does it need to be for them to know, well, you're going to get 10-20% reduction in this, but you might not get 10. So what is the cocktail of medication or the treatment out of those three you'd recommend, and how would you recommend them?
This is a great question. Actually, if I had available in my clinic the more potent ones like lomitapide and evinacumab, definitely I would prescribe them, because actually these therapies are not exclusive. Actually, the studies that Luis showed, Antonio showed, actually patients were already taking lomitapide, then they took evinacumab, or were already taking the PCSK9 inhibitors, So basically, it's not, one thing does not exclude the other. And we can use the three therapies together, Certainly if I had, and in Brazil it's more complicated because we only have them in clinical trials. Now we'll start having the donation to my patients with HoFH, and certainly I'll put them on evinacumab because I know it's a terrific medication, So I also, if I had lomitapide, easier. I have patients with lomitapide, but it's not available for most of them, right? So to make the answer very short and simple, these therapies are additive. They're not exclusive therapies, and certainly if you have the more robust ones, I would give them. I can also try the PCSK9 inhibitor on top of the other ones. I don't see any trouble, because what happens is that with a single of this, only one of these medications, okay? So let's say everybody's taking statins and ezetimibe. Then I add lomitapide, or I add evinacumab. So probably patients will need the association of them, probably the three of them, in order to really normalize LDL cholesterol, especially if you already have coronary heart disease, if you had already plaques. So definitely you need a very robust therapy in order to lower the cholesterol the lowest that you can. So basically that's how it works. And for a low middle income country like like Brazil, I think it's very complicated because this costs hundreds of thousands of euros per year. And in systems, in these health systems, it's really a challenge to provide these therapies,
Thank you, Professor. I mean, I'm quite happy to know that it's going to change into a tablet. So that's one of the good things for me. But where do you see the future for PCS?
Yeah. And there's inclisiran also, right? Inclisiran is not so bad regarding the number of injections. There's 3 in the first year, then 2 injections every 6 months. So it's not bad, right? They might not be as robust as the monoclonal antibodies, okay? So evolocumab and lidelocumab are a little bit, let's say, more strong than inclisiran, but inclisiran might help a lot of people with heterozygous FH, in my opinion. So I think this is something that we should consider now.
So with the HoFH patients, where do you see the PCSK9s going in the future? Do you see that the long-term use, where is it? Yeah, just the input into that.
Oh, they're a standard of therapy for people with heterozygous FH. I think this is a blast of science, the PCSK9 inhibitors for people with HeFH. Now, I have patients that are taking evolocumab for almost 10 years now. And I remember when I started doing the TALSIC trial many years ago, I really chosen my most severe disease patients because they had refractory high LDLs and they all had coronary heart disease, And the good news is that with the exception, I think 1 or 2 of them, most of them are doing very well, low LDL cholesterols, and fortunately they didn't have cardiovascular events after they started the therapy. And so it can really make the difference for them. So, and you don't need to be afraid of adverse events of these therapies because they're very safe, very robust, and they reduce the risk of cardiovascular disease. This is very proven in huge studies with thousands and thousands of people. So definitely, and certainly there are people with heterozygous FH involved in those studies. And definitely this is something that we must give to our patients.
Thank you, Professor. Thank you. Over to you, Cheryl.
Yeah, and I take it over for the questions. There are some questions from patients that they feel like a sort of subject that you try this and you try that. So it's even more important to have these webinars to empower the patient, that they can ask for, why should I get this and why shouldn't I get that? There is a question, is 50% LDL reduction acceptable in homozygous FH?
I think it's a minimum goal, Albert, I think, because if you start, let's say, with 400 milligrams per deciliter, 500 milligrams per deciliter, still will remain with 200, 250. So that's why we need the combinations, you know. So because, you know, Antonio showed us that evinacumab reduces by 47%, Luis showed us by 50%. This might not be enough. But remember, these patients that participated in the trials, they were already on another therapies, right? So, and the good news is that we got an extra 50% on top of everything that we were already doing. And this can really make the difference. But remember, I think one of the issues is the lack of diagnosis of HoFH and HeFH. And sometimes, even if you do all these beautiful things that we can do to our patients, it's not going to be enough to change the natural history of disease. So that's why early diagnosis and start therapy as soon as possible can really change the disease. You know, so this is how I see it, because sometimes our patients get too late. They get some benefit, but they might not benefit as we wanted them to benefit, because the longer the LDL is lower, the better for them, you know.
I fully agree. For all the audience, HoFH and HeFH is now known for us, but perhaps not for your specialist. You should say homozygous FH for them. But for us, HoFH works. Questions to Professor Massana. And Professor Massana and Professor Gallo both said you can combine lomitapide and evinacumab, but they say that's not allowed in many countries. You only can give one. So, Professor Massana, is it not hypothetical?
Well, I think the reason for not allowing the combination, first of all, is because it's difficult to get any of them. And they are not approved in the same countries. In some countries, there is one approved, the other is not approved, etc. But for scientific reasons, I'm sure that there is no doubt that the combination of both would give us a lot of benefit and give to our patients a lot of benefit. In fact, I was calculating the impact of using both. So let's say that both can reduce 50%. So that means that both together will reduce LDL by 75%, more or less. So that means that someone with an LDL of 400 can be put on LDL below 100. We have no experience, but we have, I think, friends that have a lot of experience. Well, not a lot, but some experience with combination of this. So it has been already assayed. And so I have friends of mine, Alberto Sambon, that everyone knows here. So said, it's the first time I've seen patients with homozygous FH with an LDL below 55 milligrams per deciliter. I think this is the future. So the problem is that we cannot maintain two drugs with an extremely high price for a single patient. So, but this is something that I'm sure that the FH Foundation will help us to improve.
Yes, I fully agree. Antonio, you want to add something to that, or?
Yeah, I just want to actually comment a little bit also to Marwa's questions before. It's overall a journey that we go through with the patient when we are proposing therapies, because it's really something that we are kind of experiencing together with you when it comes to the efficacy of a treatment, because the genetic background cannot be really always that clear to help us, already predict which is going to be the answer to the treatment. Of course, we try to combine the most efficacious treatment at the lowest price, but not in terms of economy, also for the patient. I mean, we don't want to overcharge and adapt treatments, you know, in order to have you with 5 or 6 treatments. If that's not needed, we try to get the most efficient one that can still allow us to get to the objectives, of course. 50%, it's not enough in HoFH. A 50% reduction, it's not enough in HoFH. We need to aim, because we can now, we need to aim at least a 70 to 80% reduction. Because, I mean, that's what we could say before. Now we can say that we can go down and we can do better, and we must do better.
Thank you. A question for Luis from Professor Massana. The one who asked the question is, it takes a long time for the body to settle down with lomitapide. How long did it take for the children to reach optimal doses? It took me 18 months of slowly moving up in dose. Is that happening the same in children?
Well, our experience with children is not exactly the same, but I'm sure that there are individual differences in adapting to the new therapies and new drugs. So I believe that someone will need 1.5 years to obtain the right dose, and more than obtaining the right dose, to adapt to the new diet and all these things that are in the sight of the use of lomitapide. But our efficacy phase was at 24 weeks, and all kids were already in a stable dose when they reached these 24 weeks. So I think that probably is not necessary waiting for 18 months.
Okay, thank you. Then to all three of you, are you in favor to first try PCSK9, or in some cases, also for the audience, when we talk about defective, we look happy, but defective is no good. Only null is even worse than defective. In defective, you have some receptors. So is then your first choice, if there are some receptors, to start with PCSK9 inhibition? First, Raul.
I would try, you know, as I said, because we have the response very quickly, and the cost is much lower than the other therapies. And if that doesn't work, or it works less than we need, we could add the other therapies. So basically, this is how I see it, you know.
Perhaps the others just not, or please add if you think it's necessary. Antonio.
Yes, I agree on the fact that we can give it a try, also because it's the easiest thing that we can try, and we can see the response quite easily. The patient for whom I wouldn't do, and I don't do it, and I'm not gonna do it, is for, you know, brothers or sisters of HoFH patients with a certain mutation that I already know did not respond to the treatment. There, I know that genetic background has been tested. It's not working. It's, you know, just time wasting to try even in another patient with the same mutation and the same background the treatment. So in that case, that's why that's what I would skip to the next step.
Yeah.
I think that even in those in which the drug will work, we will never see these patients on LDL targets with the use of PCSK9. So at the end, we will need LDL apheresis, lomitapide, or evinacumab, or combination of them, or whatever. But we will need this kind of drugs in these patients. So yes, we can try. We will start then from a lower LDL baseline when we add the other drugs, etc. But at the end, for sure, nowadays, any homozygous FH will need LDL apheresis, evinacumab, or lomitapide.
Yes, thank you so much. We're entering a new era with magic bullets, golden bullets. I believe we actually are. So I'm really happy with this discussion, and I hand over to Cheryl. It's the end of. We have dozens of questions, but we will do it. But you will tell.
Yes, yes. So if we didn't get to our to your questions today, don't worry, we'll be following up with answers in our post-webinar email. And the recordings actually of the trilogy and the FH Awareness Day webinar will be available soon. So please keep an eye on your inboxes. So we hope this session has provided valuable insights and a deeper understanding of the recent treatments in managing HoFH. So as we conclude, I want to extend my appreciation to our panelists for sharing their time and expertise. And again, happy birthday from all of us, Professor Santos. Thank you for sharing a part of your day with us. And
Thank you very
on
much.
behalf of FH Europe Foundation and Magdalena, we want to thank you all for making this trilogy possibly the best set of webinars in our history, and I quote her on that, and the incredible collaboration between patient experts and the audience, and the medical experts and patient experts, and also the audience who have been incredible. So whether you're a patient, caregiver, clinician, researcher, industry expert, your support and advocacy have made all of this possible. And we also want to thank our partners and sponsors for their invaluable support, which has greatly contributed to the success of this campaign. So thank you all and have a wonderful rest of the day.
Thank you.
Thank you.
Bye-bye.
Everyone.
Bye-bye. Ciao.
Bye.